Good morning. So from year 0 until 1830, 200 years ago. So it was, and then hygiene movement, and then contagion movement. Health protection, focus of attention, action framework, and notable events. Health protection, authority-based, the king, the tribesman, he dictates everything to us. Yes, you have to do this and don't do that. The do's and the don'ts, they say it. So sometimes it's a prophet, sometimes it's a tribesman, sometimes it's the king, the caliph, whatever. So they get, like Hammurabi, yes? Hammurabi, the king of Babylon, yes? 3,000 years ago, 1,700 BC, plus 2, 3,700 years ago. Engraved on basalt, black stone, basalt. And then 4,000 years ago, Hammurabi said that doctors, you should pay the doctor if he comes to your house. So it's the king that dictates this, okay? And it's all about religion and beliefs. Yes, they believe, they worship idols. They are Muslims, they are Christians, they are Jews, they are Hindus. So the health very much depends on the beliefs and the religion and what you worship. And many things, when you change your religion, many things change. Yeah. Notable events, quarantine. People in Europe, for instance, they used to, during the 14th century, when they had plague due to the bubonic fever caused by Yersinia pestis, fleas, and then rats. At that time, they thought it came from China to the Middle East, to the Arab world, and then go to Italy and then to Europe. Everybody used to come to the ports, Italian ports, quarantine journey, the 40 days. They lock you for 40 days, and if you have symptoms during the 40 days, you go back or they leave you to die. If no symptoms after 40 days, then you are sick-free, disease-free. Okay, so this is quarantine. And also quarantine was also in Islam. In Islam, there is something when you are hadith about from the Prophet that when you are in, let's say, in a village and there is a disease, don't come out of it. Don't go inside it. So that's quarantine. And what it's religion, but there is quarantine here. Okay, so it's all about beliefs and religions at that time, in the year 0 until 1830. So there's quarantine. There's food prohibition. For instance, Hindus don't eat cows. Muslims don't eat pigs, pork. So the food prohibition, pork and beef, even sexual practices. For instance, in some religions, you have to make abstinence and not indulge in intercourse before you are married. Or the lady should all the time be virgin. This, many things. So it depends on the religion. Religion says so and so. Polygamy, for instance. You know polygamy? Having more than one wife. In Islam, you are allowed to have 4 if the first wife allows you to, so maybe, yes. In Christianity, no. Although some groups of Christianity, some groups like the Mormons in USA, you can have 12. And what is the rationale behind this? They tell you that all the prophets, Ibrahim, Ishaq, Yaqub, all these prophets, the Israeli prophets, they had more than one wife. So we can be like them. They have, they have a logic in this, maybe. So everything was dictated by your belief and your religion at that time. Then later on came hygiene movement, sanitary conditions, hygiene movement or sanitary conditions. And people throw lots of weight on the cleanliness. How clean you are as a person, how clean is your house, how clean is your city. From cleanliness, if you are more clean, then disease will not prevail. In some religions, they believe that water should not touch you. So some people, they stay 40 years without having a shower, yeah, or washing their hands. Can you imagine? Yeah, again. So they think that the water has the microbes and they shouldn't touch you. Okay, what's your name? Wasim. Thank you, Wasim. Okay, Wasim says that they think that the source of disease is the water. So water shouldn't touch you. But I think nowadays we all know this. Maybe this was justified at that time, but now it's not. And an example is Snow, John Snow and the cholera. Yes, father of epidemiology, and how he made his first epidemiological thinking and reasoning and closed one of the pumps in London. And then all the number of cholera cases went down. And opposite to Dr. Farr, who was on the other side saying water has nothing to do with this. There was John Snow and Dr. Farr, Dr. John Snow and Dr. Farr. And John Snow turned out to be the correct one. When he switched the pump off, closed the pump from the River Thames, number of cases went down significantly. Semmelweis and hand washing. And we talked about this last time, yes, where the doctors came from the autopsy room and to help delivery, the ladies to deliver, and they killed them. Puerperal fever, yes, childbirth fever. While the nurses who washed their hands, or their hands were originally clean, when they helped the lady to deliver, she didn't die. And Semmelweis told them, please wash your hands. And the doctors never listened to him. It's only after 30 years or more or less, they said, Semmelweis, Agnes Semmelweis was correct. We should have washed our hands. We should have done this. So some people, they come up with ideas, but people don't believe them. And only after they die, they realize that these people were right. Yes. Puerperal fever. Okay, and then the contagion control. This era, 1880, 1940, which is only 60 years. And this was the period where there is germs and bacteria, and people realize that all these diseases come from or caused by microorganisms, whether it's bacteria or parasite or virus or fungus. So people realize this. And then after this, people realize that they should take care of these infectious diseases, plague, typhoid, tuberculosis, STDs in general, gonorrhea, Neisseria, syphilis, all of these. Yes. So people thought that this is the cause. Microorganisms. Kill the microorganisms, then disease will vanish. Okay, this is the idea. An example of this is Robert Koch, German, tuberculosis and others, but he's known for tuberculosis. Louis Pasteur, the French, the pasteurization of milk. Originally, it was wine. Yes, we talked about this. It was originally wine, and he saved the wine industry in France. And now every bottle of milk, pasteurized milk, after this guy. Yeah. So there are people who made lots of contribution in history. These contributions, maybe they were very small. Now they are very small, but at that time they were considered a big leap. So then these are the three. Then we came to what we call filling holes in medical system, 1950 to 80. They thought after the antibiotic development and the disease control and on germ theory, they thought that they have reached the top. Then there are lots of things missing. So filling the holes. This is missing, this is missing, this is missing to complete the picture, So that's why they put filling the holes in medical system. There are things that are still missing. They fill the holes. Integrate disease and control. Care of risk groups as part of medical care. We care about, for instance, women if there is breast cancer. We care about, let's say, prosthetic for men and so on. Sexual transmitted disease, drug addicts, maybe this. Yeah. So they went to risk groups, not the whole people. Then action work system for CDs, which is communicable diseases, infectious diseases, the CDs. Yeah, integrate prevention into healthcare. They say, why should we wait until the disease comes and then we start fighting the disease? No, from the beginning, we try to teach you some strategies that the disease does not come to you originally. From the first place, you don't have disease. Then you don't have to go all through the agony of treatment, and sometimes it works and sometimes not. Okay, so prevention. They started the prevention thing. And notable events, antibiotics. The intensive use of antibiotics, because antibiotics was introduced or discovered by Fleming in 1929, but after the Second World War and during the Second War, it was extensive use. So antibiotics, randomized clinical trials, the Framingham study on CVD. There was a study in Framingham. It's a village in Massachusetts, in USA, where after the president what's his name, Roosevelt, he died of NCDs. He had diabetes, CVD, this, that, many diseases, which were NCDs. And he died knowing not what is the cause. The doctors around him, he died in front of them, and they didn't help him anything, and they didn't know what the cause is. And then they decided, okay, we have to do a study to know the NCDs and the cause of NCDs and how to deal with it. So they started in 1949, I remember, or 48, 49, a study in this village, and this study is ongoing until now. Can you imagine? 75 years, generation after generation. Then health promotion and health prevention. 1980 to 2000, 1980, 86, started the health promotion. Health promotion, as we said last time, it's helping the people and enabling the people to control their health, so that when they control their health, the disease is prevented or reduced. Okay, so this is health promotion disease. Individual behavior, how to eat, how to sleep, not to smoke, behaviors, personal behaviors. And detect disease in risk group and general population. Yeah. STDs in drug addicts. AIDS, we know that AIDS mainly in drug addicts. So go to the drug addicts. These are our targets. Clinical and population-oriented prevention. There is the prevention, whether it's in the hospital or in public health itself. Okay, multiple interventions. Sometimes you have to. There is CVD, cardiovascular. Maybe it's the diabetes mellitus that is the cause, or hypertension. So you have to have multiple things together in order to control NCD, because NCD is a multifactorial. When you have a disease that is multifactorial, then you have your strategy to combat this disease should also be multifactorial. Yes, multiple interventions such as cardiovascular, control your cholesterol. CVD, control your hypertension. CVD, don't be obese, and many things, because it's a multifactorial disease and there is not a single cause, just like the CDs. We know that HIV or AIDS, HIV, syphilis, trypanemia. But in this case, you cannot pinpoint the real cause. You can have risk factors. Okay. And finally, the population health, which is now public health and medical care together. They unite together, plus even social system together. Evidence-based intervention. You make the treatment. You make your intervention based on numbers, not based on what you like, yeah, or what people say. You make it based on studies, health research. Okay. Example: drug resistance, antibiotic resistance. Now we have lots of antibiotics that are not working, especially if you come across bacteria like MRSA, methicillin-resistant Staph aureus. This is drug resistant. Or Acinetobacter baumannii, drug resistant. Or Pseudomonas, drug resistant. Or MDR, multi-drug resistant tuberculosis. So all of these now you have to have, and every now and then they come up with the new drugs, stronger and better, and wait for 10 years until they collapse, and then a new generation comes out, and so on. So as you see, you remember when we talked last time, and we said that we have the medical model, the clinical, where the patient goes to the hospital and it gets the diagnosis, the treatment. That's the clinical model or the medical model. And that's something very important, which you as medical students are here to do in the future. After 6 years and then 1 year in the hospitals, then you become doctors that go mainly to the medical model. Clinical, yes, you treat people, you make diagnosis, you make all of these things. That's the medical model, which is very important. And we said that health is not only that, we have further things. We talked about public health, health education, health promotion, yes? If you have, let's say, a diabetic patient, it's not only enough, or it's not enough just to give him insulin and that's all. No, you should promote health with him and let him control his health by changing his behavior. We talked about this. And then we said that there's a third factor, which is that we have social system. What is social system? Is that we have things that are not health, but at the end, they pay back in terms of health. Just very quick example, tobacco tax, smoking. When the country or any government or any Ministry of Health or Ministry of Finance usually, they increase taxes on cigarettes, tobacco, what is going to happen later on? Less people will buy tobacco and less people will smoke. So it's taxes, Ministry of Finance, has nothing to do with health, but with the tax, it paid back in terms of health. So we had social system, we had public health, the traditional, and we have the clinical care, which is the medical model. All three of these have one goal. What is this goal? Is to improve the health of the population, or we call it here population health. So population health, comprehensive concept by integration, collaboration, merging three components: public health, traditional public health, healthcare or clinical care or the medical model, as we said, and the social model. All of these together, we call them population health. And all of them lie within the umbrella of public health or population health umbrella. So according to Riegelman, to our textbook, population health is something new that includes all of these three. Okay, so let's have, these are the components. You see here. So public health, a healthcare system, medical model, then traditional public health, health promotion, health education, and these stuff. And then finally, we have the social system. Things are from the Ministry of Finance, but at the end, they pour in the health results. So, and then we have the strategies of intervention. Strategies of intervention that are in the public health and also mainly in the public health and also in the clinical care are three types. Let's have a look at them very quick. These strategies of intervention, they are meant to protect our health. Not promote, to protect. Promotion is something else, okay? To protect our health. To prevent what? 2 P's here, not 3 P's. The 3 D's. You know the 3 D's, we already talked about them. Disease, disability, and death. Okay, so these here, mainly the nurses or the doctors who work in the health departments, not in hospitals, mainly know much about this. Okay, first we have what we call primary. Exactly. So this is the primary intervention, or we call it primary health care, or we call it preventive health care. Sheer examples, clear examples of this here, the primary health care, is the nutrition. When you give good nutrition to people, especially children, then you will prevent any future diseases. Obese children, usually when they get 40, what do they get? Diabetes. So that's why if you give them good diet, healthy food, when they are at school, when they become 40, you will minimize the number of diabetic patients in the future. That's the idea, so to prevent. We do this for the children, hoping to prevent diabetes mellitus when they become 40 and above, okay? Also vaccination. We give vaccinations to the children, to the babies, from day 1 until some of the vaccines are given at age 15. Day 1, we give hepatitis B and BCG, anti-tuberculosis, yes? So from day 1 until age 15 years old, you keep giving the child doses of vaccination. Why? To prevent the disease, prevent 3Ds, to prevent the disease. That's the prevent. And sometimes we use this in daily life. For instance, when I came here this morning, I used my seat belt, you know, in the car, my seat belt. This is primary health care. So that to prevent any serious damage when a car accident occurs. So that's one example which we do use in daily life, yes? Or you brush your teeth to prevent decay, dental caries, okay? So this is a preventive, or we call it primary health care. Then we have what we call secondary health care, or curative. Secondary health care. So when you do the preventive, you are hoping not to get the disease in the first place. But sometimes the disease comes to you. What would you do? Despite all the preventive measures you are taking, disease comes to you. Then we have to cure the disease. We have to treat the disease. Either we go to the clinic, we go to the hospital, we make surgery, we take tablets, medicine, this, that, many interferences that doctors provide us with. The level where you make surgery, or you are given antibiotics, or you are giving any other drug or treatment, this level is called secondary. Usually this level in hospitals and clinics, secondary. And the primary health care usually given in the health departments, nurses, yeah. And usually this starts, even the primary health care starts when the woman is pregnant. Not at the time of delivery, even when the woman is pregnant, okay? And continues until you are old. And then the secondary, and the third, which is the tertiary. The third level, which is the tertiary. Or rehabilitation, we call it rehabilitation. So we tried at the beginning, good. So we tried at the beginning to prevent the disease. Most of the time we succeed, sometimes we fail. If we fail, then we go to the secondary. And you try to treat. But sometimes also the treatment fails. So you have to make, let's say, diabetic foot, you have to make amputation. Or car accident, you make amputation of the hand. Yes? Or chemotherapy. Chemotherapy, cancer, and it didn't work. The chemotherapy, it didn't work. And the patient, anyhow, he or she is going to die. What would you do? We make the third level, tertiary healthcare, which we call sometimes rehabilitation. When you have amputation, no leg, no hand, and they have been cut off, we have to give you what? Artificial limbs. Or if you have CVA, you know the CVA, cerebrovascular attack, so one half of your body is not functioning. So we have to do physiotherapy to you. The damage is there. The damage has already occurred, but we have to minimize this damage. Or if the patient, the cancer patient, becoming a hopeless case, and the pain is there, in order to make this patient live peacefully until he dies or she dies, we give him or her palliative care, painkillers. Instead of feeling severe pain, he or she can just feel painless until he or she dies. Okay, so these are the three levels. Primary, prevent the disease. Secondary, when the disease comes. And tertiary, when the damage has occurred. Okay, primary, secondary, tertiary. As we said, we have the population health, clinical care, public health, and the social system all together. They form a collaborative or uniform component. This population health has four components. First, we have health issues. I'm going to explain each of one of them separately. So four components: health issues. What are the health issues that this population health tackles? Then the population. What is our population? Who are the people who are our target? What is the target population? And then we have the third one, shared health concerns. In each society, there is a shared health concern. We all care about something. If you remember 2 years ago or 3 years ago, we had the pandemic. Everybody in the society talked about COVID-19. And we all shared the same fears, the same concerns, and the same ambitions that we want to get rid of this pandemic. That was 2-3 years ago. So this is society's shared health concern. This is not even society, it's a global health concern, COVID-19. Now they are talking about a new thing, which is the monkeypox, yes? Monkeypox. Did you hear about monkeypox? Monkeypox? No? Yeah, WHO just 2 days ago declared monkeypox as a global problem. Just 2 days ago, just 2 days. Because they have lots of cases in Africa, and some of the cases even reached Sweden, Europe, okay? And then finally, we have society's vulnerable groups. In the society, we have vulnerable group that is weak and that is affected by the health problem more than the others. Sometimes it's the woman, vulnerable group. Sometimes it's the babies, the children, vulnerable group. And sometimes it's the old people, vulnerable group, yes? So these are the four components of the population health. And they change over time. 100 years ago, it was something. These four components were something. Now they are another. And in the future, they will change. Let's have a look at the table where these four components are presented historically and now and in the future. Okay, this is a table. The four components: health issues, population, shared concern, and vulnerable groups. Let's have a look at these previously, now, and in the future. Look, this is historical. It means 200 years ago, 1,000 years ago. So before our time, regardless. Of course, if you go deeper in history, the change will be dramatic, drastic. 50 years ago, there will be some change, but noticed by experienced people. Yeah. So first, the health issue at that time was physical health. Everybody wanted to look good. Everybody wanted to function good. Maybe 500 years ago, we needed soldiers who are fit, I mean, with muscles, so that they can use the sword and they can fight. Yeah. So that also we need healthy community, healthy people. We need people who are well nourished. So it was at that time they cared about only physical appearance. They never cared about mentality. You are a soldier, take this sword and go and fight. Whether your mentality is okay or not, they don't care very much. They care about one thing, is that he is really big, muscles, and can do the job of fighting, maybe. Yes? Not necessarily fighting. Sometimes farmers. They needed 500 years ago farmers. Strong farmers, not weak farmers. So all they cared about at that time is the physical. And the population was only geographically limited. What do I mean by this? Is that the geography, for instance, it's only in Cairo, for instance. This is their community. This is their geography. Or in Jerusalem, Quds. Or let's say in Baghdad, or in Paris, or in Berlin. So they defined their population as the people living in that area, in that geography. And people 500 years ago or 1,000 years ago, people in Berlin or in Paris or in London, they never cared much about the people in Nairobi, for instance, or the people in New Delhi. All they cared about their geography, the people around them. So this is really, it was something geographic. And the shared concern at that time was communicable diseases. People, let's say in London, at the time of Jon Snow, they cared much about cholera. Edward Jenner, the people or the society cared about smallpox because it used to come here and then kill people. After 10, 20 years, another epidemic comes, kills people, and so on. So they cared much about the communicable disease, which is the infectious disease or contagious disease. And if we remember, we had in the eras, contagion era. Remember, contagion era, an era where you had lots of diseases that can be transmitted from one person to another. Also, there was a time when the people or the civilization, which was, I think, in the 14th century in Europe, they cared much about the plague. You know, the plague, bubonic fever, the Black Death, which is caused by Yersinia pestis, a bacteria, and the rats and the mice, they play a role here through the fleas. The fleas has the bacteria, and the fleas live on the mouse, and the mouse spreads in the society, and then the disease comes. And they say that it came originally from China, through Italy, and then Europe. It killed 2/3 of Europe. Plague. So they cared about infectious diseases. And this plague, which is the bubonic fever, also it swept the Middle East at the time of Islam, before and during and even after. And if you remember the plague of Umwas in Jerusalem, it killed almost half of the Islamic army, which was fighting the Romans. Yes, so it was Umwas. And many of the soldiers died. So at that time, all they cared about is communicable diseases. They never thought of diabetes or cancer because they never saw it, or they never even understood what is it. But the communicable disease, you can see the signs and symptoms: fever, blisters, rash, and then death. Okay. And the vulnerable groups at that time was mothers and children and high-risk occupation. For instance, soldiers. You send 50,000 soldiers to the battle, half of them die. Risky group, yeah. So we need to feed them. So they become strong and they win the battle. And also we had mothers and children, MCH, maternal and child health care. At that time, children used to die in large amounts. Yes, mortality rate at that time was very high. Infant mortality rate, and even maternal mortality rate. Very few children make it to youth at that time. They didn't have vaccines. So when the disease comes, it wipes the children. Okay, so the vulnerable group at that time was the high-risk occupation, like soldiers, maybe the farmers, women, and children. That was historically. Now, the story is different at our present time. Let's have a look how they changed. Now we care about physical fitness. We all wanted to be physically fit, although it's very difficult because life has developed in a very enormous way that we don't do any physical activities nowadays, yes? All the activities are done by our fingers, yeah? Our fingers only. Even the people are thinking of making cars that just go by them. They drive auto drive. They drive themselves. So you just sleep. Previously, when somebody wanted a piece of knowledge, maybe he or she had to walk hundreds of kilometers to get that piece of knowledge. Now you just Google it at home. So all you are using is your fingers. And then physical activity almost diminishing. Unless you make a program for yourself to make physical activity will not come to you. Previously, you have to work in the farm. You have to work, let's say, to be a farmer or some builder or something. Physical activity all the time. Men and women alike. Women used to work. Nowadays, they don't work. Okay? So it was physical and mental. Now we care about the human being being as somebody who's stable, mentally stable. No mental disorders. We have many mental disorders, many. We care about them. Previously, maybe they never cared about them because they never knew them. They never cared about them. They never knew them. If there was one case or two cases in the village with mental disorder, very severe mental disorder, they will say this is somehow spirits, the spirits, curse and spirits. Maybe they kill him or kill her or bring a clergy, a religious man to get all the Satan out and the genies and all these stuff, the spirits. Nowadays, we look differently. We say this is mental disorder. It's not a spirit, yeah? It's mental disorder. Okay, so we care about these today a lot. And we have psychiatrists everywhere, every corner, every city, every village, psychiatrist. And sometimes mental advisor. In some societies, you don't need to have a mental disorder to go to a mental advisor. Although it's a taboo in some societies, like our society is a taboo. If you see somebody with a psychiatrist, it's a taboo. You know what a taboo is? Something stigmatic. In some societies, it's okay. You go even if you don't feel anything, just to check that you are okay and you are looking at life correctly. Yeah, that's the idea. Population, local, state, national, and global. It's no longer because of the media and let's say the technology advancement. People no longer care about their village only. We don't care about Paris only, or we care about Caracas only. No, we care about the world. We care about, let's say, your country. Russians care about Russia and the war with Ukraine, and Ukrainians care about Ukraine. Palestinians care about Palestine, not only their villages, because they are now under attack maybe or something. Okay, so our concern became bigger. I mean, I can ask you, what makes the people in New York rally for the Palestinians? What makes the people in Tokyo rally for the Palestinians? And in London, and Johannesburg, and Caracas, and Montevideo, and Argentina, all of these people from the west to the east, south, north, nowadays you see them on TV, on social media, they are rallying in support of the Palestinians. Why? Because population has developed. It's no longer geographic, it's international, okay, and global. So this is the idea. Maybe this is a good thing, yes, it's a good thing that you see everybody is supporting you all over the world. If you are right, of course, yeah, people support what's right. Shared concern, as we said previously, people cared about plague, typhoid, maybe tuberculosis. Nowadays, people care about these. In addition, they care about toxic substances, pollution in the world, pollution. Let's say you have a nuclear reactor somewhere close to you, or you have a chemical factory somewhere close to you, or let's say, as we have here close to us here, we have a quarry, sawing stones, cutting stones, quarry. And this quarry produces particulate matter. And this particulate matter, on the long run, it makes, let's say, lung problems, silicosis, and this and that. Okay, so we care about this. And if somebody wants to make a factory close to your house, which is, let's say, a chlorine factory, you have to stand up and object and say no, do it somewhere else, far away from the people. We care about these things. Previously, they never cared about it. Why? Because we have lots of industry going around. And you can see the rivers. The Yangtze River in China, you can see pictures of the Yangtze River, which is the longest in China, becoming red. Why? Because of the pollution. Chemical factories on the Yangtze River, on both sides, they are pouring their waste in the river. And the river became muddy or somehow red or changes colors and this and that. Also, the other river, Ganga River in Varanasi in India, it's polluted. Of the corpses, they throw the corpses there. You know, the Indians, they have this ritual of burning the bodies after death. And sometimes the bodies are not fully burnt. They're not ashes. They're still bones and flesh. And they throw them in the river. And after some time, what happens to the river? The river loses its purity. And I have seen in the river lots of larvae and moving things. It's like a sewage. You have to clean it, although it's coming down from the Himalaya, and it should be very clean. So sometimes people, they play with Mother Nature in a way they harm the oceans the same. You have the oil tankers. Maybe these oil tankers in the oceans, maybe they wash the tankers in the sea. And when you eat the fish, you become toxified because the fish eats the parts of the petrol and this and the mercury and the arsenic and the Hg and all of these stuff. And then you become toxified. These things we care about. Ozone layer. It's a big topic to talk about. All of these we care. These are our, let's say, shared concerns nowadays. Cost of healthcare. If you want to go to a doctor, if you are uninsured, then you have to start calculating how much you're going to pay per night. Thousands of dollars. If you are uninsured, you are doomed. Cost of healthcare. Some countries, they have a very nice healthcare. Everybody is insured. Some countries, they don't. And the vulnerable group are the disabled. Sometimes the disabled in some cultures, they kill them. They get rid of them. But nowadays, we don't do this. We have the disabled and we take care about them. We take care of them. We take care of them. Okay, disabled. Frail, elderly, old people. What do you mean? Yeah. Definitely. If you are, let's say, you are in a wheelchair, UTI will come to you very frequently on a wheelchair. You don't walk. So UTI will come very frequently with you. And I had a friend like this, chronic UTI, because he all the time on the wheelchair. Exactly. I agree about with you. What's your name? Jubran. I agree with Jubran. Yes. That sometimes if you are disabled, other diseases will visit you. Hello, and then they come. Okay. Like the people, yes, crippled people with UTI and other diseases. Uninsured. Uninsured are vulnerable people. You know, if you don't have health insurance, it's really a problem. If you and your family are not covered with some sort of a health insurance, one night in a hospital might cost you $1,000 or even more in one night. And in USA, around 10% of the US people, they are uninsured. Uninsured. Official numbers from the Americans. Okay. So make sure, are you all insured? All of you. We have the government insurance and we have the private. I have private through the university, private insurance, which is very good. Every time you go to hospital, you don't pay anything. Or if you pay, it's just a premium, you pay just contribution, 10%, 5%, not more. Okay. And the elderly also, they are vulnerable group, old people, because they cannot serve themselves. They cannot feed themselves. When somebody becomes 80, you have to take care of them. So these are what we call vulnerable group, and we have to take care of them. It depends, of course, it depends on the culture. Some culture, they keep the old people, their mothers, their fathers within the family. And it's a stigma if you get rid of them. It's really a stigma, a taboo. And some cultures, you know, the children, they go out. They leave their fathers and grandmothers at home and they go out. And who's going to feed these old people? That's a problem. Okay. That's currently. All of this, what's happening now. What we expect in the future, anticipation, projection, what's going to happen in the future. Have a look. Look, emerging things, cosmetics. Yeah. Many ladies and even young men want to become more beautiful. So they play with their noses or play with their lips. Yes. Some Africans, like Michael Jackson, he wanted all the big lips of the African big lips, make them normal. So they just cut them down into normal. Like some people, you know, like maybe in Chinese, the eyes, they play with the eyes. Some people, they play with the nose. Some ladies, maybe with the breast. So all of these things are cosmetics. And some people want to make themselves like cats. Yeah, have you ever seen some people making themselves like cats and dogs and even dogs? This is cosmetic. Either you are trying to be in your ambition to look very beautiful. Sometimes you mutilate yourself. You know mutilation? Making yourself ugly, disgusting, the looking. At least to me, some people, they may say it's good. So it depends on who's yeah. The beauty is in the eye of the beholder, as they say. So cosmetics is something. Yes, it's mainly with the ladies, but also some men, they do this. Genetics, yeah, genetics, social functioning, population. Now we have this university we are in now, 10,000 students, yes, around this. It's a community. And how long you stay in the university? 6 hours, 7 hours, 8 hours? A day like this, I stay from 8 until 4 o'clock. See, the whole day in the university, in this small village. It's a community. And we have a leader, the head of the university, and we have the ministers and this and that, the heads of departments. We have the population, the people, the students are the people. So, university. Not only that, also you have on your mobile. You have Facebook account? Yes. You have Instagram? Yes. TikTok, X, Twitter, Elon Musk. Everybody has this. And you have many friends there. I have YouTube. And I have many subscribers. Maybe this is where I belong. Or on the Facebook, this is your community. And you start talking to somebody in in Argentina and Chile, and somebody in India and Mongolia and Japan, although you never knew them. But this is your new community. Facebook, X. In China, they have, by the way, in China, they have their own society, social media. In China, they have their own social media, not the Western social media, as far as I have been told. Okay? So this is a new definition of society. Is the social media society. You agree with this or you don't agree, but this is a fact. Some people would like to contact and talk and discuss things with their friends on the social media, although they never met. Although they never met. But they think it's freely that I can talk about my mother and my father and how they are mistreating me or how good they are or how bad they are. You start talking things that are very private on the social. Maybe this, and then it turns out that this is a robot, not a human being. So this is a new way or a new definition of community, social media. Okay, shared concerns. People very much care about disasters, emerging diseases like COVID-19. It's an emerging disease. Ebola, Marburg, old ones, but they emerge again. Monkeypox. People are talking about monkeypox now. WHO. The director of WHO was talking 2 days ago on LinkedIn. Disasters, if there is a volcano, if there is an avalanche, if there earthquakes, yes, if there is an earthquake in Iran, for instance, or not that sometimes there is something artificial, like in Lebanon, blackout, no electricity yesterday, for 2 days. We are reading about this, and we care about these people in Lebanon, for instance, or earthquake in Iran 2 or 3 times. Earthquake in Turkey, if you remember, 2-3 years ago. We kept following. We cared about these. Although Turks, very far away, Iran, very far away, but we care about these people. First, in the first place, because they are what? They are humans, and we are humans, and what happens to them might happen to us. So it's good if we care about them so that they can care about us. That's human being, humanity. So disaster, emerging diseases, COVID-19. Vulnerable groups, immune suppressed, people without immunity, HIV, is a, genetics, people who have thalassaemic patients together. So these are the vulnerable groups here. And these health and public health problems, we can approach them in 2 different ways. We have 2 approaches. One of them is the high risk approach, and the other is the improving the average. What is high risk? High risk is that we go only for special people in order to target, to solve the problem. Let's say we have breast cancer. Where do we go? For breast cancer, where do we go? Women. That's a good group. Lung cancer, where do we go? Smokers. We don't go for non-smokers. Maybe non-smokers might get lung cancer, but the high percentage of incidence and prevalence of the lung cancer comes from smoking. So we go for smokers. Instead of wasting all the money on the whole society, just the smokers and finish. Okay? For instance, if we find in our country that most of the HIV cases, AIDS, most of them, 90%, are in drug addicts. So our target to solve this problem would be drug addicts, not the whole population. That's the idea. High risk, okay? Or improving the average. We can focus on everybody in the society, and every person. We target every person. An example of this is that we have the obese children. Obese children, as I've said earlier, when they are 40 and above, they will get the NCDs, chronic diseases, diabetes, hypertension, CVD, this, that, these common ones. And these are very expensive diseases because if you get them, you will never be cured and you will have to take medicine, treatment for the rest of your life. Therefore, in order to prevent diabetes mellitus, DM, and CVDs and hypertension, we go and try to solve this problem at an early stage by targeting the children in school and giving them exercises, healthy diet, and all of these things. until their weight becomes normal, like the population. And after this, 40 years later, you would not have to spend millions and billions of dollars on NCDs. Okay, so you targeted the children. Let's say the weight of the children is, let's say, a child of 10, maybe the weight is 20, for instance, normally, but the obese children are 30, or BMI. We just measure them by BMI, body mass index. Yeah. So you want to make these, the obese children, the BMI for the obese children, like the BMI of the population, merged together. This way, you will prevent diseases 40 years from now. That's entire. See? Yes?
So there is like not a lot of gaps in these topics. Like, for example, the neglected diseases, like schwannomatosis.
Yes, NTDs.
Yeah,
NTDs.
even neglected by the WHO and not discussed enough.
Yes. By the way, leishmaniasis is my specialty. Yes, I have.
What can we do in our society, like, to improve these topics? Like, even the people here don't know enough about it.
Yes, yes, yes. Well, that's the function of public health and the function of health promotion. The WHO until 2-3 years ago, because we had a publication on echinococcus hydatid cyst, and it's an NTD. WHO, what's your name? Osama. As Osama says, WHO had a list of NTDs, neglected tropical diseases. And this list includes, as far as I remember, 2-3 years ago, 17 diseases. These 17, one of them is leishmaniasis. One of them is echinococcosis, hydatid cyst, and long list, 17. And what should we do? It's neglected. Nobody's taking care of it, even the governments. The idea is that there should be advocacy groups. In Palestine, what we did for leishmaniasis is that we were supported by international funding agencies, and we made lots of papers on leishmaniasis. And we tried to spread this with the help of the Ministry of Health, to spread the good word in the society. People knew what leishmaniasis is, and the doctors knew, and the nurses knew. And now every lesion, every ulcer in the skin of anybody in Palestine, first test they write, the doctors, leishmania test. Why? Because we worked for years on this, to raise the level of awareness towards these NTDs, and this level of awareness among the population and among the health team, and among advocacy groups, media and this stuff. So this is the way to go for NTDs. And NTDs, WHO is throwing lots of weight on making the NTDs known to everybody, and people talk about it by many ways, which I talked about. Yeah. So here, let's go back. Thank you, Osama. Okay. So these are the two approaches: going to rescue group or going to the entire population. This is the rescue group. If you see here, see this here, the 5% here, the 5% or 10%. This is the rescue group, and we want the rescue group to come here. So to jump and come here. That's the rescue group. Just focus. HIV, let's say, as I said, HIV in our country is mainly in drug addicts. We go to drug addicts. And just this small part, HIV in the drug addicts, it's very high. We make it like the normal people, okay? And then, just we finish with this. Or the obese children. This is the obese children. BMI, for instance, this is a BMI for obese children, body mass index. We want to make it like the normal population, so that after 40 years from now, we don't have diabetes in these children, and we don't have, our health system is not obliged to pay millions and trillions of dollars. Okay. Finally, which is better, this approach or that approach? Well, you can never say. Sometimes you use both, a merging of both, the two together. Or sometimes it's easier to go to high risk group. Sometimes it's better to go for the moving the average. And there are lots of factors that dictate this. Of them, the magnitude of the problem, for instance. How much is the problem? The budget you have. If you have a small budget, you cannot target the whole population. The expertise also you have, your expertise, the disease, how dangerous the disease is, HIV or just a flu. Yeah? So with many factors around, we can never point out that targeting the risk group is better than moving the average or the other way around or vice versa. Okay, so sometimes you may use both. It all depends on what you have: money, budget, prevalence of disease, many things. Okay, I think we have to stop here. Just a moment. Okay, we stop here. Next time we start with 24. Any questions before you go? Have a nice time and see you tomorrow.